Thanks, Maria, and thanks, Bahal Neto, for the very kind invitation. We obviously have many personal experiences, and countries are still trying to understand from each other's experience how to take advantage of the lessons that are being learned worldwide. I belong to two different institutions. One belongs to the government of the Amazonas state, which is the reference hospital for infectious diseases in Manaus, Fundação de Medicina Tropical, and also from the Instituto Leon das Maria Jean, which is the local Fiocruz in the Amazonas state. So I will talk in the following 40 minutes or so about my major experience with the therapeutical management of COVID-19. I was formerly known as a malaria person, and by chance I got involved in COVID-19 clinical trials because Manaus was one of the first cities to face a huge outbreak of COVID-19 due to several reasons, and that includes the seasonality of respiratory infections in Brazil. And because of that, we have put our team to get involved in some clinical trials. So that's what I'm going to talk to you about. The opinions that I will present here, they do not necessarily reflect institutional positions in times of COVID. It's better to speak by yourself and not by your institutions. And just to make it clear that I have not received any funding from the pharmaceutical industry for my COVID-19 clinical trials developed in Manaus. Only federal public funding from Brasilia and also from the Amazonas state. So this is the picture updated until yesterday. And I usually tell people with whom I speak that the cemetery never lies. So what happens in the cemetery is probably a good picture of what has happened, not is happening now, because what happens in the cemetery will probably reflect the situation of transmission in the previous 2 to 3 weeks. So as you can see here in the beginning of April, there is a huge increase in the curve of burials in Manaus, and that reaches a peak of almost 170 burials in cemeteries from Manaus, when the average number is around 30 to 40 burials. So there was a huge increase, and Manaus became one of the most famous cities worldwide because of the outbreak in Manaus. We have to keep in mind that despite of the knowledge we had about the pandemic in Europe, Brazil was not necessarily prepared for this outbreak. We had no ventilators enough for all the intensive care units. We had no idea on how to treat and how to do the triage of these patients coming to the health units. So unfortunately, that was the picture that lasted until the beginning of June, when there was a huge decrease in number of cases. As you see here, the number of burials, they have not increased substantially again, but there was a small second wave of confirmed cases and deaths, which luckily did not reflect in the excess of deaths in Manaus, but we're still facing a small second wave. I can tell you that it's a small second wave because the first wave was big enough to guarantee a certain level of immunity. And now what we are seeing is that because of elections in the municipalities in the countryside, there's a lot of people coming and going. The Amazonas state is the biggest state with 62 municipalities. And because of the elections for mayors, we had a relaxation in the and the social isolation that probably reflects what is being seen here nowadays. And because of that first wave, we got some experience which probably is not more than you had in Europe, especially now that you're facing a second wave in most of the countries. At least that's the information we have from WHO. Well, I'm going to talk about the past, the present, and the future of COVID-19 treatment. And before that, I would like to address the prehistory of COVID-19. I think it's key to tell people, especially those who do not belong to the infectious diseases area, that antiviral treatment, lato sensu, is something very complicated. You have a small virus with a very restricted genome. Despite of the damage that viruses cause, they are classically simple structures and therefore with much less therapeutical targets. It's not like bacteria or protozoans that we have more options and there's more room for looking for additional targets, therapeutical targets. There are a few cases of success which took decades to get developed, such as the treatment for HIV, for hepatitis C virus, and some herpes virus. All the other viruses, they still lack a good and efficacious treatment. If you get, for example, the respiratory viruses, we are living with influenza for hundreds of years, and even being very prevalent and leading to a substantial number of deaths, we still don't have a good treatment for influenza. Well, there is also oseltamivir, which could be used early in the process, in the development of the disease, but still not as efficacious as we would like to. So it has to be kept in mind that the antiviral treatment in general during humankind has been a very a tough process to get the development and the use in the daily life. Well, you know that we have a president which became also a scientist and a digital influencer of the population and of scientists and physicians as well. And that was one of his last statements for Brazil. He said, "Isn't it cheaper or easier to tackle the cure as opposed to the vaccine, or work on both, but not forgetting the cure?" Well, people who had advised him for the first sentence probably are not correct. I mean, it's not cheaper or easier to tackle the cure for coronavirus. The vaccine is much easier, and that explains the amount of clinical trials that we have now, the late stages vaccine clinical trials. That includes Brazil because of the timely infection for a clinical trial. But when we look at his second sentence, it's probably correct. I mean, we have to work on both vaccine and cure, because if we forget the cure, we're counting that everybody will be vaccinated timely and there will be no more cases. And that's not what's happening. Regardless of the vaccine, it will take some time to get the elimination of COVID-19. And because of that, we still have actually to concentrate on the cure or the treatment of this very severe disease. Well, so let's talk about the past of COVID-19. I'm sure that many of you have already seen or addressed those publications. So when COVID-19 was first detected in China, there was a run to detect specific antiviral treatment. That's a first approach. And this paper was published in Cell Research by the Chinese. And obviously, there was not much time to develop new antivirals. So the idea is to use, to repurpose drugs that we already know that have a well-known safety profile, so they should be already safe because people are using for decades, and drugs that we know that they have antiviral activity. So if you look here in this small graphs, you're going to see that ribavirin, penciclovir, favipiravir, nitazoxanide, remdesivir, and chloroquine were tested. Chloroquine has been efficacious in vitro for many viral diseases, but actually it never called the attention of anyone, nor for Zika, nor for chikungunya. But the Chinese tested chloroquine here, and apparently remdesivir and chloroquine, they had the best safety profile. You see here in the blue dots that the cytotoxicity is very low, while the inhibition of the virus is very high. And because of costs, specifically, those two drugs have called the attention of the scientific community. You see here that chloroquine actually not only blocks the entry, but the post-entry of the virus in the cells. That was tested in viral cells, so that does not reflect the respiratory tract cell, which actually afterwards we realized did not present the same effect. So because of this repurposing of drugs, ivermectin was also tested, lopinavir, ritonavir, based on the fact that people believed that AIDS patients were becoming less infected and less severe. Actually, this combination of antiretrovirals, they did not work. And then people started to think about drugs that could improve your immune system, such as zinc, vitamin D, and many other drugs, and people started to look carefully for many possibilities of treatment, probably Ramon Ibérico and cachaça in Brazil. Everybody was being thought for COVID-19 treatment. So in Marseille, this group released the first preliminary clinical result showing that in 26 patients and 16 controls, so you see the controls here in black. You see that from day 0 to day 6, apparently there was no big change in the viral load, in the respiratory secretion of patients with COVID-19. When hydroxychloroquine was used only, there was a small decrease in the viral load. And when Didier Raoult added hydroxychloroquine plus azithromycin, he saw that the viral load at day 5 and 6 was 0. So because of this very preliminary clinical study, which called the attention of the former US President Donald Trump, we all hope it's going to be a former president today, we saw actually that there was a huge interest in hydroxychloroquine, and more than that, even before more results came out, what we saw is that many physicians started to prescribe hydroxychloroquine. Why hydroxychloroquine and not chloroquine? Well, because that's the formulation mostly available in countries without malaria, because hydroxychloroquine is being used for lupus and rheumatoid arthritis everywhere. In Brazil and in many other countries with malaria, we have more access to chloroquine, which is essentially the same drug. And the major difference in terms of toxicity refers to the long use. So if someone uses chloroquine for months or years, there is a risk of deterioration in the vision. So if you do an ophthalmological assessment, there could be some damage, which is not seen for hydroxychloroquine. But in the short-term use, the toxicity of both drugs are pretty much the same. Well, because of that, we have published in our local tropical medicine journal in Brazil some questions that needed to be answered. And actually, there was an avalanche of opinions and people asking for more data on hydroxychloroquine before that could be prescribed. But, you know, the situation was severe. Health systems were collapsed. So why not using chloroquine? So the major questions was if it worked for prophylaxis, if it could prevent clinical disease or prevent clinical severity or prevent death, or if it could decrease the viral load, which could substantially contribute to the decrease in the transmission inside hospitals. So because of that, our group, who has experience with chloroquine for decades because of the Vivex malaria clinical trials we have performed, we have submitted a clinical trial, a safety clinical trial to our national ERB in Brasilia, and we were actually the first clinical trial to be approved by the ethics. They did not allow us to use a placebo arm because by then people believed that severe patients, they would have some benefit of using chloroquine, and that was why we decided not to compare chloroquine with the placebo arm, but to look at the safety of chloroquine in severe COVID-19 patients using two different doses. So supposedly the higher dose would have more benefit, and we would know exactly what was the safety of this drug in COVID-19 patients, because from China we had no information on that, and the Marseille group also did not show any side effects or safety analysis. So the higher dose that we have chosen was mostly based on these papers showing that for cancer patients, solid tumors patients, they were trying hydroxychloroquine, and they reached a very high dose of 1,200 milligrams per day for 3 weeks. That was a huge dose of hydroxychloroquine, but still the safety data showed that no patient had to withdraw hydroxychloroquine. So we thought, based on the in vitro studies and based on the fact that we had no idea on the concentration of chloroquine in the respiratory secretion where the virus actually is, we decided to look at those two dosages and compare that to a historical data on the fatality of COVID-19. So this was the paper which was first released as a preprint in medRxiv and then released by JAMA. That was the first randomized clinical trial worldwide using chloroquine for COVID-19 patients. And as you see here, because of the outbreak in Manaus, we could do this preliminary report very rapidly. We have enrolled patients from March 23rd to April 5th, and we got to access 131 patients. 81 were randomized. It was a blinded study, so the physicians, they had no idea on the dosage which was being used, and 40 patients were allocated to the low dose, which was almost the same dose used in Marseille, and 41 allocated to the high dose. So most of these patients, they had confirmation by RT-PCR, not all of them, because you could not wait for the result to get the access to the medication, but almost 90% of them had the confirmation. And what we saw, what our data and safety monitoring board saw, was that the high dose presented some side effects not presented by the low dosage patients. And when you followed these patients over time, you saw that the high dose people died more than the low dose. And both of them were not different from the historical data from fatality in the literature. There was a lot of Italian patients here that we have used, Chinese patients, stating a historical level of fatality. Well, in the high dose chloroquine arm, on the other hand, we had older patients, which also probably contributed to this curve. If you look at the safety data, you're going to see that almost double the patients in the high dose group had an increase in CKMB showing cardiac lesion. They also had more increase in the KTC, and two patients only, but only the high dosage group presented ventricular tachycardia. So because of these side effects, the DSMB decided to interrupt, to halt the high dosage group. And that was why we decided to publish these preliminary reports, because some other trials were also using a high dose chloroquine, sometimes not during 10 days, sometimes for 7 days, sometimes for longer. Some people were using chloroquine in a very high dose in the first 24 hours. So that was why we decided to report that high dose chloroquine, even being safe in non-COVID-19 patients, it was not safe in the COVID-19 patients, probably because they had cardiac alterations already. And this was the most impressive thing that we saw. And when we finished, after the preliminary publication, when we finished the enrollment of patients, we made the same analysis made by the physicians in Marseille. And as you can see here, from day 0 to day 5, you see that you still had almost 60% of positivity in the controls, but 85, 80% of positive patients still for SARS-CoV-2. So that was quite the opposite that was shown by Didier Raoult in France. So we have clearly some doubts about those data released in France and the data which persuaded many policymakers and presidents to support chloroquine for the treatment of COVID-19. As you can see here, many other observational trials showed that chloroquine was not effective for COVID-19, and that was the first randomized clinical trial, placebo-controlled, that was made in Brazil, a multicentric study published in the New England Journal of Medicine, showing that clinically there was absolutely no change when you compare controls, hydroxychloroquine group, and hydroxychloroquine plus azithromycin. So in terms of supportive treatment, in the past, what we did was the triage of patients only when they presented dyspnea. So only when they presented severe picture of respiratory disease, they were referred to the hospital. We used wide spectrum antibiotics, early corticoids. Some people decided to use early corticoids. Some other physicians decided to use high dose corticoids early. And also it came out from some studies in rheumatic disease patients that they were presenting less severity because they were using already anti-interleukin 6, interleukin 1, TNF, and afterwards some papers came out showing that colchicine was also an evident lifesaver, and also the vaccines, especially BCG for tuberculosis. The early oral intubation was the rule in the beginning, and physicians started to do the prone position, which was a way to increase oxygenation in the posterior and in the posterior lung lobes, which helped to increase the oxygen in the blood. So that's the past of COVID-19. So nowadays, what's being the standard of care, I hope that in many countries, the standard of care, therefore, is that we have no specific antiviral treatment. So the major conclusion so far is that we have no antiviral drug treatment. They've shown no efficacy in reducing mortality. We have to keep in mind that remdesivir apparently reduced the length, the duration of hospitalization. But WHO Solidarity trial showed that not even reducing hospitalization was a benefit of remdesivir. And that applies to all the phases of the disease, because many people started to state that the problem of the trials was that the type of patient was the wrong type for an intervention. And nowadays, at least for corticoids and for chloroquine, we know that in no phase for chloroquine, the drug works. This was a first paper published in JAMA. It was an observational study, but it showed very enthusiastically that methylprednisolone could help in the survival of patients with COVID-19. So because of this paper, some physicians decided to use corticoids, and the duration usually around 5 days, which is the standard for sepsis and pneumonia. Here in Manaus, we have performed more than 100 autopsies in patients in our reference center, and that paper was published just to call the attention of the findings in the adrenal gland. Actually, we had the help of a great friend and pathologist in Barcelona, Jaume Ordi, which helped us to analyze those adrenal glands. So you see here that from almost 50 autopsies at the time, 12 of those patients, they had some lesion in the adrenal glands. Most of the times, you had lesions in one adrenal gland only and not in both adrenal glands. And we have not seen severe, massive commitment of adrenal glands. And that explains that the cortisol levels were normal in all of these patients. So we called the attention in the literature for the fact that we were not seeing Waterhouse-Friderichsen syndrome, which is the failure of the adrenal glands, which stop to produce endogenous corticoids. So because of adrenal glands, at least there was no justification to use corticoids. That was probably one of the best news about COVID-19 in the autopsies we have performed. You see here some scattered necrosis. You see the thrombi that was seen in the lungs, also present here in the adrenal glands, but not in a massive way. Well, after that, Recovery published their outstanding paper in the New England Journal of Medicine showing that dexamethasone, intravenous dexamethasone for 10 days, they were quite good in terms of preventing death. And that was more clear, as you see here in figure B, in patients who were under invasive mechanical ventilation, which were probably those with more inflammation in the lungs. So you see that in general, dexamethasone helped in terms of decreasing deaths. People who were using oxygen, they also had some benefit, but the major effect was on those under mechanical ventilation. But keep in mind that if someone did not need oxygen, so this group of almost 1,500 patients, dexamethasone actually had a trend to kill more. So people have to be very careful when they use corticoids, because if you use corticoids in an early stage, like here in figure B, there is a likelihood that you increase the viral load. And if you stop corticoids, that viral load will contribute to more inflammation and probably more death. And that was exactly what we saw in our trial. We have started our trial by the same time as Recovery, but it was a single center trial performed in Manaus. We were not able to put other sites together because the timing of the outbreak in Brazil was quite different. So this manuscript was published months ago in August in the Clinical Infectious Diseases. And what we saw here in this study, which was a parallel double-blind, placebo-controlled, randomized phase 2b clinical trial, patients over 18 years old who were seen in this reference institution. The primary endpoint was mortality at the day 28 using methylprednisolone half milligram per kilogram for 5 days, and using placebo as the control. So probably what we did wrong here when we first discussed about the rationale of the study was to use 5 days. So we truly believe that 5 days is not enough for COVID-19, and 10 days, which was used in recovery, is the most recommended regimen. So if you see here, for all patients, there was no significant difference between those using methylprednisolone or control. But if you go for the older patients, those over 60 years, which are probably the more inflamed patients, you're going to see a clear benefit of methylprednisolone here in the dashed lines. But if you look at the less inflamed patients below 60 years, we saw exactly the same phenomenon. So the corticoids, they tended to kill more people than the controls. So you have to be very careful on who to treat with corticoids and the timing of using corticoids. I think that we have never seen as general practitioners, as infectious diseases physicians, that personalized medicine has to be used very careful in a single disease. So you should not have a single Big Mac to be eaten by everybody worldwide. You really have to take care. If you look at interleukin-6 increase and the dimer increase, you're going to see that those are the ones who benefit more from the use of corticoids. And in the present, we are also prescribing anticoagulant treatment for patients who have an increase in D dimers. So if you look at this paper published already in March, you're going to see that the non-survivors, they had much more pronounced increase of the dimer as compared to the survivors. And if you look here, you're going to see that those who have used heparin, they survived more over time, and that was more in parallel to the increase of the D dimer value. So the more D dimer you have, what reflects more inflammation and more procoagulant status, the more benefit you're going to have, as seen here in the red bars. Well, talking about another supportive measure, which was the prone position, we have to be careful about the prone position because you need more people, you need more time, and if it's not very well controlled, that does not actually reflect a benefit in terms of death. That's the small experience that we had in our hospital comparing people who have gone through pronation and those without pronation. And you clearly see there that there's no big difference in terms of time to death. So apparently what the prone position does is that it increases rapidly the oxygen, but over time, there is no benefit. So we have to keep in mind that the slight increase in oxygenation does not necessarily will reflect in the final endpoint, the final outcome. So the supportive treatment nowadays, the present of the supportive treatment is to do the triage of patients by hypoxemia and not only by dyspnea. So there is a silent hypoxemia that people are developing at home. If you're able to detect that using digital oximeters, you might take these people earlier to the hospital. We're still using wide spectrum antibiotics. Early corticoids are not the rule anymore. You have to use only severe patients. Last month, the 20th of October, two big studies were published on tolicizumab, which is the anti-interleukin-6. So in one observational study, there is some benefit, but in a randomized clinical trial, no benefit was seen. So we are still lacking more robust clinical trials to understand the real benefit of this very expensive, but it makes a lot of sense to use anti-IL-6 because the most severe patients, they actually have huge amounts of interleukin-6. The early oral intubation was substituted by the non-invasive supplementary oxygen. It works much better. If you can wait a little bit more, the better for the patient. The prone position does not lead to a sustained oxygen increase. So unless you really have people experienced and you can use those people for pronation, especially in people who are obese, you have to think carefully about that. And anticoagulation now is the rule in patients with high D dimers. If they don't have increased D dimers, I would be very skeptical about the anticoagulation, but more clinical studies are being weighted. Well, and what's the future, just to end up this presentation, what's the future of COVID-19 treatment? Well, we have published this nice review talking about how the heart is important, and at the end, in the intensive care unit, you end up with a patient with sepsis, with a compromise of the heart, and if the physician does not pay attention to all these parameters here, certainly the unsuccess is guaranteed. So physicians, they have to be very careful on when and how to monitor the D-dimer, interleukin-6 and ferritin, and patients evolving to shock, they usually have a multiple organ failure. So if you don't have a well-trained physician in the bedside looking for the presence of myocarditis, thrombosis, arrhythmias, you're probably going to have an unsuccessful treatment of that patient. Unfortunately, we have no idea on how to predict those who will develop the most severe disease. Well, do not forget the co-infections. We have published 2 cases of patients who died of COVID-19. And during the autopsy, what we saw is that those patients, they also had invasive aspergillosis in the lung. So you clearly see here that was sequenced, showing that aspergillus was the cause of this inflammation in the lung. We have no idea to what extent these co-infections happen. For influenza, it's pretty common to see aspergillosis associated to severe influenza. And for COVID-19, the more papers we read, the more we see in the autopsy series that you have to be careful about those co-infections, in specific severe invasive aspergillosis. Which are the other potential interventions? Well, there are nice reviews showing that hyperimmune plasma works. The problem is the feasibility of giving hyperimmune plasma to everybody, as well as the cost of monoclonal antibodies, which are also probably a good thing to do. I think we have lost a lot of time doing trials with chloroquine, azithromycin, and many other useless drugs that we could have used all this time to motivate more sites to do the use of this indirect immunization, which actually helps people which are severe. And of course, we still have no idea on how to manage these patients, but definitely there's not a single recipe for everybody. Those who see patients every day will see very similar patients, and one patient simply has fever, cough, no more than that, and the other patient with the similar characteristics will increase the dimer, will go to the intensive care unit, and eventually will die. We are still pending on these immunogenetics studies to support our guidance in the intensive care unit. There are many candidates. I can tell you that one of the major targets of the immunogenetics studies are the polymorphisms of ACE2. As you know, ACE2 exists in all tissues, but not in a single concentration. Apparently, men have more ACE2 in their tissues because it's linked to the X chromosome, as opposed to women, in which, due to lionization, you have different levels and types of ACE2 throughout the body. So ACE2 is a good candidate, but so far we cannot use that routinely in the day-by-day care. There are also markers as well that should support us in the future, such as HLA and interleukin 6, but to present, that's only a dream come true, that we have something to guide us on the treatment based on individual immunogenetics. Well, I'd like to thank, after this presentation, my team, the chloro-COVID and MET-COVID teams. They were very supportive and faced a war during the first big outbreak in Brazil, here in Manaus. They were a team of approximately 200 people that included master students, PhD students, scientists, physicians, physiotherapists, many people who really devoted at least 4 months of their lives to help the others. And we are very proud of this team. Thanks very much. And I hope you still have some time for questions. Thank you.